All right, guys, so we're going to jump straight into our webinar today. So for those of you that are new to this series, this is only the second one that we have ran, but this is a little bit of a collaboration series between New South Wales Health Pathology, point of care testing, and BD Life Sciences. So Ellie De Leon and myself will be running these, and I'll take you through exactly what's involved. A couple of things I just want to mention right at the start is you'll see that there is a QR code there that you can scan in, and I will get all your details then, and I'll be able to register you on My Health Learning. Fully aware that QR codes don't always cooperate, especially over this platform. So you'll also see on the side I've given you my number and also my email address. So feel free to use either of those if that works better for you. And just make sure though when you do, you just tell me your full name, your staff link number, and the facility that you're at. And one last little side note that I am going to mention is the weather has turned quite unfortunate here where I'm sitting today. So if for any reason something does go pear-shaped and we do drop out, please be aware that Ellie and I will work something out. So what we will probably do is schedule in to do a pre-recording, and we'll make sure we get that out to you should worst case scenario happen. What I'm going to do now too is just pop everybody onto mute except Ellie and myself, just to limit any background noise that we might get, and then I will unmute everybody at the end if there's anyone who's got any burning questions. So just give me one moment, I'm going to get that all done now. Okay. Ellie, can you just do a sound check for me?
Yes, testing, can you hear me?
Lovely, excellent. All right, let's jump straight into it. So firstly, I would just like to do acknowledgement of country and say that New South Wales Health Pathology and BD Life Sciences acknowledge the traditional custodians of the lands on which we work and pay our respects to ancestors and elders past, present and emerging. I am coming to you from Wiradjuri country today, and I am a proud Wiradjuri woman. And Ellie, whereabouts are you today?
I'm coming from Daru country today, so yep, welcome everybody.
Beautiful. Thank you. Okay, so the first thing I do at the start of this series is just give you a little bit of a background into your presenters and who's talking with you today. So as you would already be seen on your screen, we've got Ellie De Leon, who is a wealth of knowledge and a fabulous registered nurse. She's been working in the clinical field for the last 25 years, has a bit of a specialty for ICU nursing, and has spent the last 11 years with BD Life Sciences. Ellie has an incredible wealth of knowledge, which is one of the reasons I reached out to her, because we acknowledge that there is a lot of preanalytical issue in not just the laboratory space but the point of care space, and it just seemed like an ideal opportunity for us to come together and give you guys something pretty special. And then there's yours truly. So I'm also a registered nurse. I've been in the nurse education space for the last 5 years. Before I jumped into point of care as their clinical training coordinator, my passions lie in remote, regional, emergency type nursing, and that's us in a nutshell. So the webinar series that we've put together, at the moment you'll see it is a 7-part series, but that's not to say that Ellie and I won't bring you more. So if there's something that you feel is missing from this series or something that we haven't covered, we'd love to hear from you to tell us what more we can do for you. So series 1 was a few weeks ago, and it really was just a bit of a simple introduction into the preanalytical space, and just just a general run through of how this program was going to work. But as you'll see now, we're going to focus on Series 2 today, which is on hemolysis, which is a huge preanalytical issue across the board when it comes to blood collection, no matter what you're collecting the blood for, if you're sending it to the lab or if you're going to run it on a point-of-care device. Series after that, there's Series 3, 4, 5, 6, 7, and I won't go into too much depth about them today, purely just because this one's a bit more detailed than the first one, so Ellie and I have a lot of content to get through. But I'll run you through Series 3 at the end and what to expect, and in the future you can also expect things on sepsis, capillary collections, order of draws, and all sorts of weird and wonderful preanalytical error. So, Ellie, I'm going to let you jump straight into it.
Okay, thank you for the intro, Amy. Yeah, so let's get started. So as Amy said, last week we touched on, well, not last week, the last webinar, we touched on why the lab would reject your specimen samples. And the 5 bullet points that I have up there are the 5 main reasons why the lab would reject your sample. So these include hemolysis, specimen contamination, insufficient sample volume, clotted specimens, misidentification and mislabeling. So today's series will purely focus around hemolysis. So next slide, thanks Amy. So what is hemolysis? So as we all know, red blood cells, what's the function of a red blood cell? Is to carry oxygenated blood to all the cells in our body. But the main component inside a red blood cell is that we have thousands and thousands of hemoglobin molecules inside. And we need the hemoglobin to attach to the oxygen molecule to transport that oxygen around into the body. So therefore, when a red blood cell ruptures, it's actually the intracellular components inside the red blood cell that actually contaminate the serum or plasma. And predominantly, as I said, a tiny red blood cell contains tens and tens of thousands of hemoglobin molecules. And it's the enormity hemoglobin molecule that breaks off into a heme molecule and a globin molecule. And it's the heme part that actually makes the serum or plasma turn into a pink to orange to red colour that contaminates the serum or plasma. So it depends then on the amount of rupture of the red blood cells that determines the degree of hemolysis. So therefore, if the sample is hemolyzed, the lab will have to reject your sample because it can create or lead to inaccurate results, which I'll talk a bit more in detail in the following slides. So next slide, thanks Amy. So as you can see here, so the 2 pictures that you can see on your screen, they are pictures taken from one of my busy emergency hospitals in Queensland. The picture on the left is a beautiful serum sample where you can see that after it's spun down, it has a straw amber colour, and this is what the scientists want to analyse all the analytes with. But as you can see, the sample on the right is, more to a red to orangey colour in the serum, and this indicates that there is a huge amount of hemolysis or rupture of the red blood cells that stain and turn that serum to that reddy orangey colour. But what happens back in the lab on the instrumentation side of things, that they use infrared light to analyse and detect these analytes. So red on red can't analyse anything. And if the scientists do analyse a hemolyzed sample, what you'll find is that you'll have false elevation of some analytes due to the higher intracellular concentrations. You also get dilution of some analytes due to higher extracellular concentrations, and it can actually interfere with some test methods as well, but it depends on the amount of analyte interference depends on the degree of hemolysis. So depending on, from that straw, beautiful amber colour to a light pink to orange to red colour. Next slide, thanks, Amy. So let's have a look at some of the analytes that are really affected from a hemolyzed sample. So just say, for example, if the scientist went ahead and analysed your sample, these are the results that will be misinterpreted or will become erroneous. So, for example, analytes that are falsely elevated by hemolysis include an increase in your ALT, AST, CK, iron, LDH, lipase, magnesium, potassium, urea. It lengthens prothrombin times. Analytes that are diluted by hemolysis include a decrease in your albumin, your ALP, sodium, GGT, glucose, red blood count, hematocrit, fibrinogen, and it shortens your APTT times. So when you have a look at the number of analytes that is on that screen, at the end of the day, they are one of the most very common blood tests that the clinicians use to help diagnose and treat their patients. So technically, if the results were inaccurate, at the end of the day, the diagnosis and treatment of the patient could be given the wrong treatment, and potentially, worst case scenario, could lead to adverse events and even death to the patient. So this is why the scientists have to reject your sample. So then, what are some of the tips and tricks then I can give you along the way is how to get that quality sample back to the lab. So as I said in series 1, we want the best in vivo sample. So what I mean by that is at that point, at that time, you stab your patient with a blood collection needle to get that blood from their vein. You want what is represented inside their vein is represented exactly in the blood tube. So let's see some of the tips at what we can do to get a good quality sample back to the lab. So number 1, depends on where you get and access the vein from. So when we're talking about venipuncture, the best veins are always when you've got the tourniquet on. The 3 big juicy veins that we want to go for is in your antecubital fossa region, so which is where your elbow crease is. And those 3 veins that pop out are the one is the biggest and the largest is the median cubital vein, which sits straight in the middle. Your second vein is your cephalic vein, is the one that runs in line with your thumb. And the third vein is your basilic vein, which is opposite to your basilic. So when you put the tourniquet on, they're the 3 major veins that I want you to feel and palpate for. Why? Because they're the largest, they're the biggest, and that's where you're going to get the best blood flow. But be cautious though. If you do choose the basilic vein, often, what lies lateral to your basilic vein? It is technically you have your brachial artery that's located there and also your median nerve. So therefore, I often say in no textbook or workshop that you ever come across is that if you hit and miss, so just say you go into a vein with your blood collection needle or wing set and you don't go into the vein and you actually don't see a flashback, what people tend to want to do is to move the needle in and out, fishing for a vein. That's not a technique that we ever endorse. The reason why that is that if you were to use the basilic vein, potential complications that could happen is you could hit the artery or you could hit the nerve. And if you hit the nerve, well, what will happen? The patient will have sharp shooting pain going up and down their arm. The needle will probably fly out. You could sustain a needle stick injury, and the patient will probably most likely say rude words to you as well because they're in such excruciating pain. But sometimes when you put the tourniquet on, you only have the basilic vein to choose from because the other 2 you can't feel and palpate. It's just a caution that if you do use the basilic vein, that we never ever dig around. If you hit and miss, I know that a lot of the hospital policies advocate that you're only allowed 2 attempts. So if you fail after your 2nd attempt of venipuncture, you must escalate this to a senior person to collect blood. Thanks. Next slide, Amy. So skin preparation. would you believe it, that your skin prep, so either or, so typically for routine venipuncture, a 70% alcohol swab is sufficient to clean the skin. But if you were doing a blood culture or a IV cannulation, you must use the 2% chlorhexidine combined with the 7% alcohol. Always follow your policy and procedures in regards to prep you use, but even on which skin prep you use, it's really, really important how you clean the site. So in New South Wales, most hospitals follow the New South Wales PIVC policy, and in that policy it stipulates that you use friction and to clean the site, and you clean the site for up to 30-second scrub. So in the old times we used to do concentric. So what I mean by concentric is that we used to do circular, circular, circular in a concentric motion. But the new research now state that we clean in a crosshatch fashion. So to do that, you start from one side and you're scrubbing with friction, and you're scrubbing one way for the 15 seconds. And then once you've scrubbed that for 15 seconds, you scrub the other way for another 15 seconds, okay? And the key point is using friction, because they want you to get into all the nooks and crannies of the skin cells, because we want to remove the skin flora that's on the surface of the skin. So for example, if you were going to do a blood culture, if you don't scrub the skin appropriately or an IV cannulation, you can sustain a bloodstream infection, or if it were a blood culture, it could come back as a false positive. But once you've cleaned it, but the key is to let the prep dry. Did you know that the biggest culprit, as I said, the alcohol that becomes contaminated with the tip of the needle, the blood collection needle that you're using, that the alcohol that contaminates the tip will burst 10,000 red blood cells. So therefore, like, you've even like thousands and thousands of red blood cells even before you got the blood into the blood tube. So the key is to let the area dry. So again, to reinforce, if you use the 70% alcohol, it's an air drying time up to 15 seconds. If you use the 2% chlorhexidine combined with the 70% alcohol, the air drying time is up to 30 to 45 seconds. So again, it's always follow your policy and your procedures. Thanks, Amy. Next slide. So tourniquet, another big culprit or cause of hemolysis. So regardless of what tourniquet you use in your facility, there are different types of tourniquets around. So a lot of the hospitals are promoting a single-use type of tourniquet where you use it once and you dispose of that in the waste bin. Otherwise, some other facilities use a seatbelt type, cloth type tourniquet where it stays with the patient the entire time they're in hospital, and once the patient's been discharged, that tourniquet gets disposed of. But again, to reinforce that this one tourniquet is only used for that one patient only. We don't share the tourniquet between patients because of the risk of infection. So regardless of what tourniquet you're using there, the golden rule is the 60 seconds, okay? The reason why that is that if your tourniquet is on longer than 60 seconds, what can happen is that you can cause hemoconcentration of red blood cells sitting in the patient's arm. That hemoconcentration can lyse a few thousand red blood cells. So it's really important that you release it within 60 seconds. And most people often ask me, Ellie, you know, when should we release it? So rule of thumb, I always say, once you go into the vein with your blood collection needle and you put the first blood tube on, that's roughly about 60 seconds, and then you release the tourniquet. Because it is a fallacy to think that people often used to think that we leave the tourniquet on for an entire time to get all the blood. That is incorrect, because you will get fresh blood from your venous return with each heartbeat. So therefore, you release the tourniquet within that 60-second mark. Another thing too is the height of the tourniquet. So the tourniquet should be at least 7 to 10 centimeters above the insertion site. So just so we're talking about, we're looking for those big juicy veins across the antecubital fossa. So roughly, I always say, ladies in the room, around about 4 fingers is roughly about 7 to 10 centimeters. And if you're a gentleman, your fingers are normally a little bit larger than ours. So I normally say 3 fingers for the gentleman. And I often say 4 fingers for ladies, and then boom, tourniquet should be at that area or that height there, because if it is too high, you won't get adequate venous engorgement, and if it's too low, you'll get venous engorgement, and to the point that sometimes when you go into the vein, it can actually cause a bruise or a hematoma. So it's really important that the height of the tourniquet is also an important factor. Another thing that we see clinicians do as well is that once you've got the tourniquet on, we shouldn't do fist pumping, because what happens is that the evidence have found that if you do the fist pumping, the red cells go boom, boom, boom against my tourniquet. You'll smash a few thousand red blood cells. We never also hit or slap the insertion site where the veins are, because the hitting and the slapping on the surface of the skin will also smash a few thousand red blood cells. So all we do is put the tourniquet on, tell the patient to do a closed fist, and the veins should predominantly come up. Thanks, Amy. Next slide. Device selection is also important. So a lot of your hospitals advocate that you use a closed evacuated system to collect your blood. So as you can see on the screen, that we have, most facilities should be using the BD Vacutainer blood collection set. And the bottom one is your all-in-one multi-sample needle. So again, each facility is different. You may have different equipment out there, but as long as you follow your policy and your procedures to know how to use them correctly. Thanks, Amy. Next slide. So also as well, if you are a nurse or a doctor, and depending on what facility you work at, is that most clinicians, nurses and doctors, they have to do a separate competency to be able to access what we call central venous access devices. So in that category, it includes everything from a PICC line, a central line, a portacath, a vascath, an arterial line, or whatever other accesses that you have there. Follow your policy and procedures how to access the line. We have strict policies in regards to cleaning, strict policies in regards to doing a discard before you collect your blood from the line, and then once you've collected the blood, you must flush the line as per policy. But we also have safety devices out there to keep you nice and safe, because there's no wrong or right way to collect blood. We just have different devices there to help keep you safe and to help collect a quality sample at the end. Next slide. Thanks, Amy. So these two devices that you see on the screen. So the first one is your BD Vacutainer Luer Lock Access device. So with this particular device, as Amy will show you in her slides as well, so in point of care, you attach the Luer Lock Access device to the end of your wing set or your butterfly to collect your blood sample. You could also use the Luer Lock Access device and you could connect it onto the end of your freshly inserted cannula. And again, I do advocate, most policies only advocate that you do only collect blood from a freshly inserted cannula. Once you've used it and flushed it, we're no longer allowed to access that cannula. Or we can put your Luer Lock Access devices on any of your central venous access devices to collect blood. The other thing as well is a BD Vacutainer blood transfer device. So that one is used in a scenario where you've got blood in a syringe, okay? So however you've got blood in a syringe, and then you need to somehow transfer that blood into a blood tube. So you may see some clinicians, and you may be one of those clinicians that are still adopting this practice, where you may put a needle like a hypodermic needle on the end of a syringe. And if you do that, what happens is that most clinicians will stab the top of the blood tube. That is not a practice that is advocated in your facilities due to the increase in needle stick injuries and due to the increase of hemolysis. What sometimes other clinicians may do, they may end up popping the lid off as well and then squirting the blood in. That's also not an endorsed practice, because popping the lids off can give the incorrect amount of blood filled in the tube, so you get an incorrect blood to additive ratio, and also you could get a splash injury. So what the blood transfer device does is it allows you to carefully transfer blood from a syringe either into a blood tube or a blood culture bottle. So I'll just do a quick demo. You would pop your syringe onto the end of the transfer device as you would hold your tubes in an upright position, and you would just slide the transfer device over the top of the blood tube, and the blood gets sucked into the blood tube due to the vacuum. Or if you had blood cultures, again, scrubbing the tops of the blood cultures with your alcohol wipe for the 30-second scrub, letting it dry for another 15 seconds, and then you can pop the transfer device over your blood culture bottles to safely transfer the blood into the blood culture. Once that's done, because it's a sharp, must be disposed of in a sharps container appropriately. So again, it depends on your facility. You may or may not have these devices, safety devices to keep you safe, but most facilities within New South Wales should have these devices to collect blood. Thank you, Amy. Next slide. So again, I sort of jumped ahead of my slides, but in regards to a syringe method, so basically if you transfer blood from a syringe method without using a transfer device, there's chances of insufficient sample volume. You can cause some clotting. So again, it's a 60-second rule, okay? So basically you've got 60 seconds to transfer that blood safely into a blood tube or blood culture bottle, because the syringe does not have surfactant or lubricant, so therefore up to or after the 60 seconds the red cells can stick to the side of the syringe, and if they do, when the plunger moves down the side of the syringe, you can actually squish a few thousand red blood cells. So remember, it's a 60-second rule again, so therefore you can cause hemolysis. So again, we always advocate that you use a safety transfer device to transfer blood. Thanks, Amy. Next slide. So again, your gauge selection is really, really important. And again, each facility have different wing sets or butterflies that you use. But the traditional 25 gauge, okay, was never ever meant to take blood from adults. It was only meant for neonates and neonates only. The reason being was that the 25 gauge was basically too small. It will squish the adult red blood cells. But nowadays, with the newer technology with the BD Ultra Touch push button collection sets. So with the new technology, what we've done with all the gauges is the wall is ultra thin. So by making the needle wall ultra thin, we're able to open the internal lumen of the actual gauge. So therefore, red blood cells can flow through easily and cause less hemolysis. So depending on your facility, most facilities within New South Wales should have the new generation of the BD Ultra Touch blood collection wing sets, but you may find that if you are using older wing sets, never to use a 25 gauge, because the chances of increased risk of hemolysis. Thanks, Amy. Next slide. So your insertion technique is very important as well. So typically, you insert the angle around about a 15 to 30 degree angle to access the vein. But obviously, we have sometimes, a bigger sort of, a bigger patient, a lot more adipose tissue to go through, so therefore bigger the angle. But as I said, it's really, really important that there's no fishing around, because if you're we need to try and avoid rotating or changing the angle of the needle, because otherwise this can actually lead to a traumatic draw and can lead to a hematoma and cause hemolysis. So again, no fishing around, digging around. If you hit and miss, you hit and miss, you dispose of the sharp in the sharps bin, and you have your second attempt to try and get the blood. If you still fail after your second attempt, you must escalate that to your next senior person to collect the blood for you. Thanks, Amy. Next slide. Oh, and that was my last slide. So over to you, Amy. So this is from a point of care perspective.
Yeah, no worries. Thanks, Elle. So we'll jump straight into it, guys. My piece is just a little add-on into the point of care side of things and why hemolysis is such a big deal in our space as well. So everything that Ellie's touched on is applicable across in point of care as well. So everything that she has said absolutely gets adopted into point of care. But there's a few other little things we just have to think about. And the first thing that I always try and get across in point of care is just to remember that there's no lab safety net in point of care. So what I mean by that is sometimes we collect a sample, it might have been a difficult sample, a hard sample to collect, we send it to the lab, and we know that if that was a truly a bad sample that was going to give us erroneous results, the lab will pick that up and call us and tell us we have to do a recollect. We don't have that luxury in point of care. So a lot of my job is helping you guys, nurses, doctors, collectors, to understand how we cause erroneous results, how we can identify them, because ultimately if we don't do that, we don't pick up where our preanalytical error could have affected the result, we could end up treating a patient for a condition that they don't actually have, and that's a huge patient safety factor. So just as a little FYI before I jump in, is that we did run a lot of face-to-face preanalytical workshops prior to COVID, ruining everything. And the last statistic I did, which would be different, a little bit different now, but we took 236 staff and we asked them what hemolysis was. 87% did not know. And that's just to highlight that if you're sitting in this room today and you're like, okay, this is completely different to what I thought hemolysis was, you are clearly not alone. And Ellie and I will both tell you that we have been a statistic as well during our careers. So another thing I just want to remind you of too is you saw that beautiful picture that Ellie popped off earlier of where you can visually inspect a centrifuged serum sample and you can see the hemolysis there in that picture. Point of care, we use whole blood samples and there's no centrifuging of that sample before we run the testing. So just be mindful that unlike those tubes that go to the lab for testing, we're not going to be able to visually determine if our sample in point of care is hemolyzed. So some things that you might see from the point of care space is you will see if you've hemolyzed your sample, you'll often see that rise in potassium. You might see a decrease in your ionized calciums and your sodiums as well. And it's for all the reasons that Ellie's already listed. So those difficult collections, slow collections, tourniquet use, vigorous mixing, storing samples directly onto ice. Things like that are all going to contribute to hemolysis. And what I'm going to do is just give you an example of a case that happened actually here in the facility that I work at. This woman was a 42-year-old, very fit, very well, no history of comorbidities, that suddenly felt dizzy. She's come in, we've taken a sample for point of care and it's come back at 6.5. Thank goodness the staff looked at that and, well, a certain staff member looked at that result and went, I don't know that I believe it. And fantastic that she did, because on the other end, we had a doctor already preparing medications for hyperkalemic management. But she said, look, just before we go and give these hard-hitting drugs, let me do a recollect, which she did. On attempt 2, she got 5.7. Much to the patient's disgust, she went, oh, I really want to stab you a third time. I don't know that I still believe that result. The third time that she took blood on this patient, she got a result of 4.1, and everybody was satisfied that that was indeed the correct result. And the reason they were satisfied with that result was that very first collection that was done that gave us the 6.5 potassium. It was taken directly from a cannula. Now, the cannula was a little 22 gauge. So for those of you who don't know, 22 gauges we're often putting into our bubbies. So she's tried to pull blood out of a small cannula, and she actually had to exhibit quite a bit of force. And ultimately, she hemolyzed that sample. The second attempt, where she got a slightly better result, but she wasn't very comfortable with it, she used a 23 gauge butterfly. Now, usually there would be nothing wrong with that, but she did have to dig around and fish for veins, like Ellie said earlier, and she did have to pull on that plunger quite excessively to get that blood to draw into the syringe. And it did bubble and froth a little bit, and it wasn't exactly easy. So on her third attempt, though, she used a 21 gauge butterfly. She hit the veins straight away. The blood flowed beautifully, and as a result, she got a much more accurate result. And thankfully, due to that, the doctor put all those hard-hitting medications away, and the patient was not treated for hyperkalemia. Had she been, it could have been disastrous. So as I've already mentioned, and we won't touch much on this, but excessive pulling on the syringe plunger, whether you're doing the method like at the top picture where you've attached your point of care syringe directly to a butterfly, or whether you've got like the bottom picture and you've attached it directly to a cannula. In either scenario, if you find yourself pulling excessively on the plunger, the blood is bubbling, it's slowly trickling out, things like that, we need to be aware that we could be causing hemolysis and be mindful when we're reviewing our results. Ellie's already touched on prolonged tourniquet use, so I'm not going to touch on that any further because everything she has said still applies if you're collecting point of care. It's also really important to make sure you're thoroughly mixing your sample in your point of care syringe. So we advocate for 10 seconds of rolling between the palms and then 10 figure eights just to thoroughly get that heparin through that sample. The other thing that you might see happen in point of care that causes a rise in potassium is the clot is clotting, and it's from using plain syringes. So I'm going to jump straight in and tell you why that's an issue for us. So Ellie said 60 seconds for these guys for when they're collecting. In point of care, we say 10. So after 10 seconds, if you've collected a sample into a plain syringe and you plan to use that for testing on your point of care device, in 10 seconds, microclots are going to start forming in that syringe, and our point of care devices are as sensitive as anything to them, and we end up seeing erroneous results, and one of them being those false potassiums, rise in potassium. So this is what we often see. You'll see on the left I've got a picture of the old needle and syringe straight into a lab tube, and then on the right what we then see is when there's leftover blood, people do a decant from the plain syringe, and that in my hand there is a point of care pre-heparinized syringe. Obviously for both of these, absolutely not. We don't want to be seeing them. Ellie's already touched on these devices, and I think they're a game changer. I love using them as a nurse on the floor. And how we can put them into the point of care space is, obviously, if you are collecting pathology for the lab, as Ellie's already run through, that's where your red-topped blood transfer device is going to come in handy. eliminate those needles, eliminate the risk of hemolysis. For us, there's never going to be an excuse, and never going to be one that us, like us guys in point of care, will accept for decanting from plain syringes into point of care pre-heparinized syringes. Now, the reason for that is just the high risk of preanalytical error. There's really no need. Most syringes are designed to be able to secure directly onto the bung, whether they're luer locked. Even if they're slip tipped, it's just a matter of turning the syringe slightly when it's in the bung, and then it locks in lovely and you can pull your sample out. But often what I do here, and this is the last little tip and trick I want to give you for the day, I'm like, Amy, people often say to me, well, Amy, that's fine if I've got no choice and I need to collect blood from a cannula, or it's even okay if I'm just attaching my syringe directly onto the end of a butterfly for point of care. But what about those times when I've got to do a venipuncture and I need to get some pathology for the lab and also some point of care? It's too hard. And this is where we often see people resort to a 10, 20 ml syringe full of blood and then just decant into everything that they need later. What I want you to practice from here on in, when you get the opportunity, is a system similar to this. I want you to grab the luer lock access device. So he's usually the guy with a blue top. I want you to grab your pathology tubes that you need. I want you to grab your point of care syringe, your butterfly and your bung. If you're using a butterfly wing set that has that little luer adapter on the end, very carefully remove it. Remember, there's a sharp under there, and dispose of it in the sharps container. Then I want you to pop your bung on the end in its place. From there, for your formal pathology, attach that luer lock device that Ellie showed you earlier directly to the bung, and then you can collect your formal pathology tubes. Now, this creates a closed system. It creates a better quality sample. And then once you've collected the formal path, you can then detach that luer lock access device, attach your point of care syringe directly, and then collect your sample for point of care testing. One of the questions I do get asked is there an order to that, Amy? Not necessarily, but a couple of things I want you to think about. If blood cultures are a part of this process, then absolutely they will always come first. Blood cultures trump everything else. A couple of other things I want you to think about though, depending on whether you decide to collect your lab tubes first or your point of care, is there is air in that line. So if you're really interested in a gas result, you are going to pull some air into that line with your point of care sample. That could be enough to skew your results slightly. The other thing to be aware of, and Ellie actually brought this one to my attention yesterday, is if for some crazy reason, and it could happen, say you collected your point of care first, and then you, for whatever reason, pushed a little bit of that heparinized blood that was already in the syringe back into the line. Any pathology tubes that you collect after that could potentially be laced with a little bit of heparin, which we could see, again, impact on your results. So whilst there's no right or wrong to what's going to come first, the chicken or the egg, there are quite a few things to consider, and that this will always come down to your clinical discretion. So ultimately, in a nutshell, we just want to get through that hemolysis does cause incorrect results. One of the big ones is that increased potassium. The increased risk, then that increases the risk of incorrectly treating your patient. And obviously, if we do that, there are huge ramifications for yourself and for your patient. Now, just lastly, if you are online and you do want some more resources on hemolysis in the point of care space and some of the things we've talked about today, there has been a case study developed on this. It is available. It also includes some tips for super users and educators to keep teaching their staff about hemolysis. It's pretty fun. I like using water balloons to get the point across. This is available on the New South Wales Health Pathology website. What you need to do is either whether you're using the internet or the intranet pathology site, you need to go to clinical services, point of care testing, resources, and then it will be in the super user training folder. Now that's all a lot of information to give you right there and then, so you can also reach out to me directly and I'd be happy to provide this with you, or to your local point of care coordinator in your area, and they'll also be able to give you these resources. So that's about it from us. Series 3, just quickly, we will release a date for that soon, but we're going to focus on the order of draw, the effects of not following the order of draw. And it's funny how many people might be sitting there going, what's an order of draw? It's surprisingly not well known. We're going to talk about blood to additive ratios, sample volumes, the importance of filling volume in the citrate blue tubes. If you're a nurse sitting there, there's probably been a stage in your life where the lab has sent that back to you and told you it wasn't full. We're going to tell you why and how to fix it. And we'll talk about mixing and correct mixing techniques. But that's about it from us today. So we have gone a little bit over, and I do apologise, but this was a really big one where we had a lot of content. I'm quickly just going to unmute everybody, and we've got some time for some questions. If you have a burning question that you don't want to ask in this forum as well, please reach out to Ellie and I later, because we'd be more than happy to chat with you. So do we have anything from anybody before we say good afternoon?
Hi, Amy. I'm sorry, I don't have my camera on. I just don't have my computer set up properly. My name is Chelsea. I'm a midwife CMC, but in a prior life, I was the blood collector for Pathology West. So I absolutely loved all of this. And I was just wondering, will this be recorded to be able to share with more staff?
Absolutely, it will be. Series 1 has also been recorded, and we have recorded today's. They will be available on the website. It's obviously just got to go through a process with my comms team. The minute that they are up, I will make sure to let the coordinators know, who can then stretch that message far and wide for you.
Excellent, thank you.
And thanks for the feedback, that's really lovely.
No, that was great. On my list of things was to do a pathology in-service. So pretty much I'll just wait until these are released now, and that'll tick off that job. Thanks.
Fantastic. Any other questions for today, guys?
Well done, Amy.
No, thanks very much, and well done to Ellie. All right, guys. Well, we're going to let you go then. If there's no other questions, reach out at any time. Big thank you again to Ellie from BD and her team for taking the time with this series. We hope you get a lot out of it, and we'll see you all for Series 3.
Thanks so much, everyone. That was great.
Bye. Thanks, everyone.